file. We will be having a keynote address by Dr. Sheikha Noura Qassimi, who will be talking on uveitis, basic infectious uveitis. Dr. Qassimi, please.
Here. Okay. Thank you so much. Good afternoon, ladies and gentlemen, dear colleagues. Thank you for inviting me as a speaker. Congratulations for the 81st edition of the All India Society of Ophthalmology. Thank you for the great work, the scientific and the steering committee. Today I'm going to have to start this session, uveitis session, with a classification and overview in uveitis as a nutshell. So what is uveitis? It is an inflammation of uveal tract, not only limited to the uvea, but can also involve other ocular structure such as retina, vitreous, or optic nerve, and sclera. There are different presentations of inflammatory eye diseases, and
slides are not seen.
Oh.
Slides. Slides are not shown. Yeah.
Yeah. So the inflammation, uveitis is the inflammation of uveal tract, not only limited to the uvea, but can also involve other structures such as retina, vitreous, optic nerve, and sclera. Different presentations of inflammatory eye disease when the patient presents, whether ER, referral from an ophthalmologist, or even referral from other dear colleagues from other specialties. So there is a great working group called Standardization of Uveitis Nomenclature SUN Group. This is an international expert committee which follows the aim to develop this as standardized and internationally recognized terminology for the field of uveitis. So as a uveitis specialist, we talk same language, and this made us pave the road for diagnosis and even discussion among colleagues. For example, a description of uveitis. As an onset, we have a standardized terminology, whether it is sudden or insidious. The duration, if it's less than 3 months, it is limited. However, more than 3 months, persistent. The course of the uveitis in general, whether it has been categorized as acute, recurrent, or chronic. Again, SUN has worked also as an anatomical classification. We are not only uveitis, we are detailed of sub-uveitis. We need to have a clearer mind map, and SUN has been classified as per the anatomical classification. Anterior uveitis, where the site of inflammation is in the anterior chamber. Intermediate uveitis, where the vitreous is the site of the activity. However, the posterior uveitis, retina, or choroid. Overall, the 3 layers if the activity is involved, such as AC, vitreous, retina, or choroid, it is panuveitis. And even this is a well-known diagrammatic, has been published or worked by SUN. We are not only uveitis or doctors, we are also investigators. We follow like Sherlock Holmes, that we have a very low threshold. So we ask for the patient as a detailed questions, the duration, exposure of whether this is a trauma, just to have, it's not a usual redness post-trauma, could be sympathetic ophthalmia, photophobia, whether this is, this also add a lot to our diagnosis, changes of vision, reduction in acuity, halos, visual disturbances. This is also as leading us to differential diagnosis. Discharge, because a lot of patients, they've been underdiagnosed by uveitis simply because the family physician or general practitioners, they diagnose as conjunctivitis. Past ocular history, previous episodes, previous herpetic eye disease, previous eye surgery. Nevertheless, we are investigator. We investigate and review of system from top to toe. So those great lists, this is as our putting in our every new patient, we have a detailed thorough review of system, like respiratory for TB, sarcoidosis, GI for inflammatory bowel disease, and which is really common among our population, musculoskeletal for the like GIA or HLA-B27 related arthropathies, skin for Behçet disease, sarcoid or psoriasis, CNS as an MS. Why it is important? Because when we correlate those classification anatomical, this will guide us also that systemic manifestations in the body, really there is a strong correlation in initiating uveitis. So HLA-B27, it's well known for anterior uveitis. MS is for intermediate. Posterior, there are a lot sub inflammations, retinitis, whether focal or multifocal, and well known also diseases which cause focal or multifocal choroiditis. And nevertheless, there are well known diseases for causing panuveitis. International Uveitis Study Group has categorized or classified uveitis as the relating causes: infectious, which we are going, this is the session is all about, non-infectious, and masquerade. We are not only doctors, we are not only an investigator, we are also divers in oceans. Why I'm telling that? Going to our investigation, examining now the patient, we are grading the AC as a flare, and cells, and we have to take a long time and being patient just to evaluate and appreciate how many cells in general in an AC. Nevertheless, even in the vitreous as a haze, and we grade it accordingly. Investigation is important in diagnosis, management, and follow-up, such as OCT, fluorescein angiography, ICG for choroidal disease, electrodiagnostic tests, and visual field. And this is, I'm not going to talk about the investigation because it needs another one session. And we are a puzzle expert in a sense that after having the examining the patient thoroughly, taking a proper history, and doing the accurate investigation, nevertheless, there are certain blood work and chest x-rays needed, and there are like a baseline and selective. So we are just collecting the information and applying it on our mind map and for the next step forward. So we have to complete the puzzle in order for the diagnosis with the investigation, so we can tailor the management. Also, if we are clueless and there are such important and non-resolving the activity, or it's getting worse, or it is not improving with the management, our initial management, it's not shame to step backward, revise this, the study, the case itself, discuss it with our colleagues, and we can have another top-up investigation, and this is also an important to be discussed today. For intraocular fluid samples for infectious, as a viral, bacterial, parasitic for Toxoplasma gondii, fungal for Candida, and also as a masquerade to make sure that this is not a lymphoma, so we take fluid sample. There is a great study in the Ocular Immunology and Inflammation Journal, a focus of the epidemiology uveitis, and it shows that it is around idiopathic is the most common form of uveitis. However, infectious causes are common 30 to 60% in the developing countries, like herpes, Toxoplasma, to TB, syphilis. However, in non-infectious uveitis, conditions are generally more common in the developed country. Again, talking now, going deeply into the infectious uveitis, when we know that it is one of the main causes in the developing countries for uveitis. There is a study in 2016 saying that uveitis due to infectious etiologies account for between 15 to 20 cases in the United States. However, it may likely account more in a significant proportions of uveitis worldwide. So what are the infectious uveitis in general? And our dear colleagues and experts are going to talk later on. Bacterial, parasitic, viral, such as herpes, HIV, fungal candida, and not to forget that we need to, as an ophthalmologist or a uveitis specialist, not to underestimate, and we have to teach our colleagues, residents, trainees, and fellows that we need to always dilate the patient. Why? Because a dilated fundal examination is absolutely mandatory in every case of anterior uveitis. Remember that viral retinitis, which we are going to talk later, can cause blindness within days, and they can be mistaken for a non-infectious anterior uveitis. Of dilated exam is a mandatory, and if it's not performed. Even if the vision of the fundus is haze and not clear, we have to rule out if there is any presence of white or yellowish lesion, which denotes retinitis or choroiditis. And if you cannot be sure, I always stress this to my residents, to do ultrasound just to rule out how the vitreous is inflamed or how severely is inflamed. So this is why we dilate every patient. We presume that it is really healthy macula. However, if we miss the periphery. So we are not an ophthalmologist. We are not only divers. We are not a puzzle expert, or we are even an investigator. So we are not only to discover. We follow the steps. Thank you so much for the presentation and listening to me. And on this podium, I'm inviting you all to attend our Emirates Society of Ophthalmology conference in February 2024 in our beloved capital, Abu Dhabi.